Good evening. My name is Mary Morris. I'm a reproductive endocrinologist and infertility specialist at Boston IVF. I work out of mostly the Stoneham office, but I also work out of the Waltham office. I've been in Boston for my entire adult life, and I'm happy to be here with you, and I'm happy to take your questions. So I'm going to read the question. What's the timeline for getting pregnant after scheduling a consultation with a fertility doctor? It can vary. I generally tell people, it's about 6 weeks to get everything done. It can be as soon as a month. Then there's a follow-up visit, and then the time frame from there also varies quite a bit. It can be pretty immediate, depending on insurance approval and things that are completely out of our control. So I generally say expect about a month before you get started with any sort of treatment plan. What other questions? Let's see. Should you take prenatal vitamins during IVF? Um, the answer is yes. You should always take either a multivitamin or prenatal vitamin anytime you're undergoing any sort of infertility treatments. I include that in when you're freezing eggs and not intending on getting pregnant or freezing embryos. It's just overall good for your health. Make sure that you're in a healthy place before you start all of this. The major factor we want to know about is the folic acid, because if you are getting pregnant, it's important to take those about 2 months prior to getting pregnant to reduce the risk of neural tube defects. How many PGTA embryos do you need for 3 kids safely? That's a great question. I generally say double the number of embryos that you want to have for children. So if you want 3 children, 6 would be a fairly good number, but there's so much variability in people's experience with this. Some people have 3 euploid embryos and wind up having, or PGTA tested, I should say, normal embryos, and they have 3 healthy pregnancies. There are people who have 8 PGT normal embryos and wound up with 1 baby. So it is highly variable and dependent upon the couple. Let's see, any recommendations for maximizing IVF success when age is likely the biggest factor? And the answer is to do all the things that your parents told you to do growing up, hopefully. Eat a balanced diet, get adequate sleep, get moderate exercise, drink lots of fluid, decrease alcohol, decrease exposure to chemicals and anything that's negative in your environment. Unfortunately, there's nothing you can really do to get around the age factor. It really has to be sort of a numbers game, if you will. The larger the number of eggs you can get, the higher the probability that you'll get a good egg that's going to form an embryo and hopefully a healthy pregnancy. I have an embryo transfer coming up. What would you recommend being the most important at this stage and immediately after the transfer? Oh, I think I just answered that one. That's kind of the same. There's a question about exercise. That's a tricky one. If you're an athlete and you are used to exercising, I don't see any problem with it as long as you don't get overheated. Muscles and ligaments loosen up during pregnancy, so it's actually easier to hurt yourself. Your sense of balance changes when you're pregnant. But around the time of transfer, I just say do what you ordinarily do as long as you don't get overheated. So no hot yoga, no hot spinning, because it does raise your core temperature. We also, if you've had a stimulated cycle, ask that you avoid bouncing. So, running exercises, could potentially put the ovaries in a situation where they could turn on themselves and cut off their own blood supply. And that can be quite painful and also require surgery. For the transfer, do you prefer the natural process or through medications? That's also a great question. Um, It depends on the patient. For a patient who has normal, predictable, regular bleeds, the natural cycle can be lovely in so many ways because there's so much less medication. There's a little more intensive monitoring because we don't know when you're going to ovulate. Um, for people who have irregular periods, sometimes we can do what's called a modified natural cycle, where you take either medication called Clomid or letrozole or even purified FSH, and we monitor that process and force the ovulation at a time we can predict with what's called a trigger shot. Some people say, look, I fly to New York every Tuesday and Thursday, and this has to be on Wednesday, the 25th. For those people, I'm going to say, you might be better served with a medicated cycle. There is some data arising that people who do a natural cycle are at lower risk of certain pregnancy complications late in pregnancy, like preeclampsia. Again, this is a very sort of new literature, so it's not quite clear that that's 100% sure or why the reason would be. But it really is, in my clinic, sort of patient driven by what their lifestyle is like and what they think they can do. Do you have any suggestions on a brand of prenatal? I do not. There are brands out there that I know people like, but I think, you just go to your CVS and get a routine prenatal. It should be fine. Like I said, it's really the folic acid in it that we want you to start taking beforehand, and eating a healthy diet. What is the turnaround time for PGTA testing? That depends on the lab. I think our turnaround time is about 2 weeks, but it can take up to 3. So I tell people always be patient and just wait. And you can always ask us, and if we say no, that's okay. We'll try to give you some time for him to reach back out, or when we're going to reach back out. When should I use baby aspirin in an IVF cycle? Also a great question. It is indicated in some people if you have, say, a clotting disorder or certain medical conditions, but in general, it's not recommended during an IVF cycle, certainly before retrieval, because of the risk of bleeding that comes with aspirin. Some people take it after a transfer. Again, I don't feel strongly about it unless there is some clotting disorder that a hematologist has weighed in on. For patients with endometriosis, when do you recommend surgery over medications? And this also is a great question. We know that people with endometriosis, it's a bit of a struggle for them to know exactly when to have surgery. For my own patients, I say, if you're symptomatic, you should certainly consider surgery. There is a little bit of a boost in pregnancy rates after endometriosis surgery for about 3 to 4 months after that surgery. Bear in mind, though, endometriosis can be kind of tricky. If you do surgery, and particularly if you have large cysts on the ovary, removing them can be helpful to us if we're doing IVF, because it helps us access those ovaries and those follicles that we're trying to retrieve. But when those cysts are removed, there's normal ovarian tissue that's inevitably removed with it, and that can cause a lower ovarian reserve. Can we transfer 2 embryos at a time? And again, that also depends on a lot of situations. In general, for women who are 37 and younger, who have never had a transfer, have only had 1 transfer, in general, we recommend a single embryo transfer in those women, unless there's some outstanding circumstance. If there are tests, and if you're over 38 38 and older, there are American Society of Reproductive guidelines that weigh in depending on the number of transfers you have and, again, certain situations. For people who have tested embryos that are PGTA normal, we recommend one embryo at a time because the risk of multiple pregnancy is quite high in those situations. Is pregnancy after the age of 43 possible through IVF? And the answer is yes. It's just more difficult based on the chromosomal abnormalities that start to catch up with women as they pass through years. So you need really more eggs for the hope of getting an embryo that's normal and that will implant. We do IVF cycles to the mid-40s. You can undergo egg donation cycles or where you receive donor eggs or embryo donations, and the transfer, I believe, is up until 50th birthday. Oh, this is a great one. What are the odds of getting pregnant in your mid-40s if you use frozen eggs from your late 30s? Obviously, depending on embryo viability. I've had a lot of these patients come back through the years, who bank their eggs in their 30s and come back in their mid-40s. And it's whatever the age that they were frozen at. So there is a graph in a paper that basically is just like a nomograph that tells you that for this number of eggs retrieved at this age, there's X probability of having a baby using those, or 2 babies or 3 babies. And so if you're familiar with that paper, it's produced by somebody named Joseph Doyle. And if you type that in and type oocyte cryopreservation, you can see those graphs. What is the average cost of fertility treatments? I'm sorry I asked that question because it really depends on center. And if you are interested in Boston IVF, we have lots of financial counselors and insurance. And Massachusetts is a mandated state. So most private insurances will cover it if you're like a state employee or if you're, hired by a company that's based in Massachusetts. There's some on the outside that don't provide, but I can't really speak to the cost of it. Let's see. Somebody asked if they should stop taking folic acid and CoQ10 before transfer or when the pregnancy is successful. I would not stop your folic acid at all during pregnancy. At any moment, you should continue taking it. The CoQ10, we really don't have a whole lot of data in pregnancy, so I generally tell my patients to stop when you start your stimulation. But again, there's not a whole lot of data for CoQ10 in pregnancy. Oh, also a good one. What's the egg retrieval process like? This question is coming from somebody who was congenitally born without a uterus, and she's looking into freezing her eggs. It's the same process. So IVF involves going through a process called controlled ovarian hyperstimulation. I think this is what most people think about when they're doing IVF, of taking these injectable medications. There are generally 2 to 3 of them, and they last up to 2 weeks. During this time, you come in for 5, 6 appointments that are early in the morning, 15, 20 minutes for blood work, ultrasound. You get a message back later that day once we have all your results of instructions for your medications, going up, going down, staying the same, and when to come back. At some point, we say you need to take that trigger shot. This is going to cause those eggs to mature, and 36 hours later, you undergo an egg retrieval. This is a super simple procedure. You're asleep for about 10 minutes under IV sedation, heavy sedation. You're not intubated. It's just a mask of oxygen, IV medications, and a small needle goes through the vaginal wall directly into the ovary. We use some suction to pull up those eggs. And again, after about 10 minutes of being in the operating room, you're waking up and going to the recovery area. For people without a uterus, it can be trickier to find the uterus, excuse me, to find the ovaries because the uterus is kind of home base in a pelvic ultrasound. But once the stimulation medications are started, the ovaries get bigger and bigger, and then these folks, it is easier at that point to find ovaries. For IUI cycles, can they be done back to back? Absolutely. It's just like ovulating on your own. You know, go through this medicated cycle again. The monitoring process is about 2 weeks, very brief appointments, not every day. For IUI cycles, it's generally 3 or 4. You have your IUI, and excuse me, I should tell everybody, IUI means intrauterine insemination, where we take the best sperm, put them in 1 drop of fluid, and place it high up in the uterus where it's closer to where the eggs are ovulated. Once you have that IUI, you either get a period or have a pregnancy test, and if you're not pregnant, you come back in and do another one. So they're generally done back to back. How far in advance do you need to plan a frozen embryo transfer? For example, I want to be pregnant in a certain month. When would you start scheduling the transfer and get started with medications? Depends on a few things. One is that it depends on when your testing was done. We need updated testing. And for these frozen cycles, it's a few hormones and looking at your uterus in some sort of way, like a saline sonogram or a hysteroscopy. Once that stuff is completed, it can be, I'd say, 4 to 6 weeks. It, again, depends on whether it's a natural cycle or a medicated cycle. But I'd say start, if you're interested in, say, for example, July, I would reach back out to your doctor and say April or May, and say, what testing do I need to get done, if anything, and how can we start setting this up? Is 42 years old too old to try fertility treatment? No. I have plenty of patients who are 42 and year older. Is a saline sonogram painful? That's the answer is going to be subjective. I can't say it's everybody's favorite experience. If you've had uterine procedures like an IUD placement, it's something like that. But again, it varies from person to person. Basically, it's a speculum exam. We place a catheter through the cervix into the uterus. After we do that, we inject sterile fluid, saline fluid, into the uterus, and that opens up the walls. The uterus is a big muscle, and when you perturb a muscle, it's generally going to contract, and that's what causes crampiness in this procedure. So it can vary from anywhere to mild cramping to severe pain for some people. And when people have pain, I just say, hey, let us know, we'll stop, we'll figure out some other way to get this done. So my partner has low sperm count and motility and low progression. I've been trying for a year. Is there anything he can do to improve the quality, and would you say IVF would be necessary? Again, this is somewhat dependent on the parameters. Some parameters make it amenable to doing, say, an IUI, intrauterine insemination. There are some parameters that are so low that I would suggest going straight to IVF. Again, it depends on the parameters. And I also look to urology and a urology consult to help guide me. Now, that being said, I've been doing this long enough that I can say, oh, yes, this is definitely IVF would be the recommendation. But at the end of the day, everything is a recommendation. And nothing has to happen in the way that, is recommended. It's a conversation. What is your experience with probe development? Is a female a carrier of a certain disorder? Have you seen this before? And it again depends on the disorder and the company you're using. I generally say a couple of months is required, but again, I've seen it take up to 4 months, depending on how rare the disease is and how many family members are affected and how much information they can get from you and your family. Generally, the more genetic information these companies have, the easier it's going to be for them to make a probe. How far in advance will I know exactly what day my egg retrieval is going to be? And that's a day and a half, 36 hours. When you start, the nurses can generally sort of paint out in very broad strokes a range of dates, but even that is just an estimate. It can be before that, after that, but we really don't know until that day of trigger. And that's 36 hours later. I had 3 failed IUIs and was going to move forward with IVF and ended up pregnant right before, but had a miscarriage. I'm sorry, that's terrible. What would you suggest as next steps? Really checking back in with your doctor. It does take a while for that pregnancy to resolve, and generally we don't do anything during that time. Again, depending on a lot of things about the pregnancy, we may want to repeat a saline sonogram or hysteroscopy just to look inside the uterus. And then in terms of fertility treatments, it's personal. Again, if you got pregnant with one of your IUIs, you may say, hey, I'm going to back down to that and just try it because it worked. You generally get your best outcomes within the first 3 months of trying anything, including natural conception, IUIs, but IVF wouldn't be a wrong answer either. Again, I try to take my cues from my patients. If they said, hey, I think I want to try this again, absolutely. But if you're also eager to get started and do IVF, that's also a very reasonable plan. What is the best way to find out whether a tea we like to drink or a collagen supplement we use is healthy during pregnancy? Would this be a question for our nurse via the portal? This is a hard question. There are a lot of supplements out there, and it's hard to know exactly what's in them. Even ones that list ingredients, sometimes there can be contaminants in them. And I think most nurses are not comfortable, and I'm not comfortable answering a lot of these questions via the portal because I don't know exactly what you're taking. Um, there, for example, you know, chamomile tea, that's fine. If you want to drink mint tea, that's fine. But a lot of teas, if you've gotten from herbalists, we really have no way of knowing what's in them. Can you please explain embryo grading? If an embryo is BC, is there still a good chance for a live birth? Can the grades improve as time passes? So this is a complicated question. So embryos are graded on 3 distinct features. One is the stage in development. So for example, on day 3 of development, it's a cleavage stage. By day 5, 6, and 7, it should be what's called blastocyst. Anything short of that is considered lower quality on 5, 6, or 7, but I've even had pregnancies result from those. They can't be frozen. You could do a fresh transfer and potentially have a pregnancy. Assuming a blastocyst on day 5, 6, and 7, so that in some clinics or labs gets a number, and that's generally 3 through 6. So 3 is just a solid blast. 2 is an early blast, I should say. 4 is an expanding blast. 5 is a hatching blast. 6 is a fully hatched blast. All of those are great quality embryos. The second digit in those 3 is an A, B, C, D, so forth. And that's the grade of what's called the inner cell mass. That's what forms the fetus. So A is good, A is excellent, perfect, B is good, C is kind of really small, and D is absent. And then the last digit is also a letter, A, B, C, D, and a C trophectoderm is totally fine. B inner cell mass is good. I have plenty of people get pregnant. I've had patients who had a 5AA transfer, didn't get pregnant. They come back for their 3BC and they get pregnant. So, the grade matters, but it's not the only thing. It's not everything. Can you still do IVF with both fallopian tubes blocked? Absolutely. This is why IVF was invented. Egg and sperm, generally the egg ovulates onto the fallopian tube, sperm after intercourse migrates out to the end of that fallopian tube, and that's where they meet. And then the embryos travels back through that fallopian tube. And so about 50 years ago, the first IVF was ever invented for a couple for whom the woman had blocked fallopian tubes. There is certain tubal pathologies or diseases where we recommend having the tubes out. This is in the case of what's called a hydrosalpinx or a hematosalpinx. So salpinx means fallopian tube, hydro means water, hemato means blood. So the fallopian tubes are filled with water or blood. And that can lower your chance of pregnancy by half. So if you are going through IVF, we make the suggestion, again, that you have a damaged fallopian tube out. But the fallopian tubes are absolutely not needed for in vitro fertilization. When do you recommend second transfer after a live birth? Well, that depends a lot on how the first live birth went. For people who have had a C-section, obstetricians generally suggest a year after that C-section for healing of that uterine scar that's created. That has been moved out in extenuating circumstances. After a vaginal delivery, generally say at least 9 months and up to a year. And again, a lot of this is dependent on whether you're breastfeeding or not. Breastfeeding lowers your probability of success. So we also tell people to, finish breastfeeding the baby you have, and then you can gear up and get ready for your next transfer. So interesting one. I've done IVF. I'm almost 7 weeks pregnant, just had an ultrasound. Everything looks great with a good fetal heartbeat. Congratulations. But I have bleeding. This is incredibly, incredibly common. The most likely outcome for somebody who has bleeding in the first trimester is also a healthy outcome. Bleeding can come from a lot of places. One is the cervix. So after the ultrasound, the cervix is quite fragile and has a lot of tissue that can be disturbed easily and result in bleeding. It can be coming from what's called a subchorionic hematoma, which are also very, very common in pregnancy. They are not correlated with a miscarriage. Most of them resolve. Again, very common, so I wouldn't panic yet. I'm not saying that you're not going to have a miscarriage, but I do think that this is a very, very common thing, and most of these pregnancies go on to be healthy. Can you please talk about silent endometriosis? Endometriosis is a tough diagnosis. It's tough to make, and it's a tough diagnosis. It's tough to have endometriosis. If I were to, say, walk out onto the street and find 100 women I know nothing about other than their reproductive age, and were to do surgeries on them called a laparoscopy, which is a simple procedure, not that anybody would do this experiment, probably about 10 to 14% of those women would have endometriosis. If I walked into a fertility clinic and gathered up 100 women without talking to them about pain or anything like that, close to 40% of them would have endometriosis. And oftentimes the only way you can diagnose endometriosis is surgically and taking tissue and hand it off to a pathologist and them telling you this is endometriosis. That is the only way to truly diagnose it. Now, that being said, I have a lot of patients who have presumed endometriosis, either based on a cyst or imaging like an MRI that says this looks like endometriosis. For women who have extraordinarily painful periods, there is, and suffer with infertility, there's a good chance that is endometriosis. Again, I can't make that diagnosis without some sort of surgery, but I presume it. Um, so just so you know, I can't really answer any questions about cost. I did try to answer one, but it's kind of not my role any more than, say, the financial coordinator could tell you anything about medications or their effect. For a woman in their 40s, would you recommend trying IUI first or try to create embryos from eggs frozen in their 30s? Or, yeah, so that's the question. If someone's in their 40s, should they try IUI, create embryos from the eggs that they have frozen? I generally say those eggs are your backup plan. So if you're now partnered or you're thinking about getting donor sperm, I would undergo an IUI because it could work. You're still in your reproductive years. And then I would use those frozen eggs for potentially a second child or a third child, maybe even. Again, a lot of this is dependent on what your studies show. Are your fallopian tubes open? Is there a male factor if you're partnered to a man? A lot of things weigh into that. I was told I have PCOS several years ago. I'm now in my late 20s. I've been trying to conceive for a year and have very irregular cycles. If I'm having period, does that mean I'm ovulating? Or can you have periods and not ovulate? I'm so frustrated. I'm sorry. Yeah, that is frustrating. You can ovulate with PCOS, but just because you bleed doesn't necessarily mean you ovulated. So there's a buildup. So in the normal menstrual cycle, estrogen is very high for the first half, and then estrogen drops in the second half. And after ovulation, the cyst that produced that egg makes progesterone, and that matures the lining for implantation. If there's no implantation, then a period occurs. And for women with PCOS, there's this perceived chronic high exposure to estrogen. And what can happen over time is that can become unstable if there's no ovulation, and there could just be this bleed. It's sort of release of all the contents of the uterus. So it doesn't necessarily mean you did ovulate. The good news is that for somebody with PCOS, getting them to ovulate is usually very simple. There are great medications that we have, both Clomid and Letrozole, or that can help you to get to ovulate. And if you've been trying for 3 years, I would certainly say you need to see a reproductive endocrinologist and see what they can do to help you along those lines and make sure everything else is normal, like your fallopian tubes are open and your male partner has sperm. With fibroids, would you expect your periods to be regular and or heavy? So fibroids are a tumor of the muscle of the uterus. And when I say tumor, it's not cancerous. It's just an overgrowth of that muscle. The uterine muscle is amazing. it can grow in hypertrophy like no other no other muscle in your body, which means it can be prone to overgrowth. And so you can form these hard uh, sort of lumps of tissue inside the uterus, and they can be inside the uterus itself, inside the lining. Those tend to be associated with heavy bleeding and sometimes some irregular bleeding. They can be in the muscle, just underneath the uterine lining, and mostly in the muscle, and those can also result in heavy periods. If they're inside the uterine wall or outside, hanging off the outside, they generally don't cause heavy bleeding. They can cause pain. So again, the degree of heavy bleeding or pain that you have is dependent on the location of those fibroids, with them being more inside the uterus, causing more heavy bleeding. But they don't cause irregular bleeding unless they're inside the uterus and sort of necrosing or in the process of dying off. There's a question again about starting the IVF process, about having a baby, and they say they're breastfeeding. I do recommend that you stop breastfeeding, because when you breastfeed, your pituitary produces, due to the stimulation, nipple stimulation, your pituitary produces this hormone called prolactin, and prolactin shuts down the communication between your ovaries and your pituitary. And initially that could be quite profound. And as you breastfeed less and less, that level drops. But there's still this thought that the even slightly high levels of prolactin, even though they might not cause irregular periods, they may cause a lowering of fertility. I was diagnosed with primary ovarian, they typed in primary ovarian failure here. It's actually called primary ovarian insufficiency. My AMH was very low. My FSH was high. I'm actually having regular periods. Can I conceive naturally, or should I seek care? If you're actually having periods, it's not typically considered ovarian insufficiency if they're regular, every month. If they're irregular, it may be consistent with that diagnosis, depending on how frequently you get them. Again, it depends on how many children you want to have, or how aggressive you want to be. But I think for young women who have with the diagnosis, which I think you actually have, is diminished ovarian reserve, if you want to have children, I would absolutely seek out an opinion. You don't have to do anything after the appointment. Just get the opinion, try to understand why they would want you to have testing and what you should do next, according to their thoughts. What are the chances of getting pregnant with one large fibroid? Do you have to have fibroids removed for IVF? They can cause a lot of problems with, I shouldn't say fertility, but with reproduction. And one is that they require quite a bit of blood. And so when you become pregnant, it's like a pregnancy and the fibroid are somewhat in competition. They can also grow quite a bit in pregnancy because of the hormonal changes, and they can undergo stripping of they outgrow their blood supply, and they undergo a process called necrosis where they die off. And that can set off a pattern of inflammatory events that can cause preterm labor. That's pretty rare that happens. It depends, a lot on the blood supply of that particular fibroid. If you leave it in place, though, it can cause dystocia of the pregnancy, meaning that the fetus has a hard time turning and coming out vaginally. So they can disrupt that process as well. And fibroids it's really hard to make that decision. Again, I generally tell people, if you're symptomatic, consider having it removed. And if they're in a certain location, considering having it removed. But it is bit of a shared decision between yourself and your doctor. How does one with PCOS track ovulation? I've gotten multiple positive ovulation tests with one cycle, so I'm not sure I should trust those. And that is also a really great question, because people who buy ovulation predictor kits, if you follow the instructions, you're supposed to start tracking at a certain time, and that's not really relevant for you. The other tricky part about this is that some women with PCOS have very high levels of that hormone LH, which you're measuring. And so if that's tonically high, meaning always high, you're always going to get a slightly positive, but no real peak in fertility. And that can be just overwhelmingly frustrating. So it's very hard. And I tell patients, don't use the ovulation predictor kits, because they will literally drive you insane and they're expensive. So you're somebody I would check out, trying to meet up with a fertility specialist and see what recommendations they can make for you. Do regular periods mean good ovulation? In general, yes. If they occur at a frequency that is very predictable to you. What makes it more reliable is if you have symptoms of ovulation, for example. Um, some people get a headache before they ovulate. Some people get a headache, like a migraine headache, before their period. If you have cramping, if you have breast tenderness before your period, those are also all good signs that you're ovulating and that your hormones are cycling. Sorry, I'm just trying to see which ones I've answered and which. How soon can I jump into a second IVF cycle, meaning how long after the egg retrieval can you typically start up cycle 2? That's a great question, and it depends on the circumstances and a lot of other factors like insurance. For people who you can do back-to-back cycles, what it means is that when you come in for your second cycle, there may be these complex cysts that are left over from your prior retrieval. They're not going to harm anything. They can make the follicles in your ovary more difficult to see. If they're producing hormones, sometimes it's best to wait until the next cycle, but in general, cycles can be done back to back. When they're not, it's for specific reasons. One, patients want a break. The second one is insurance doesn't want to approve it until they have an outcome for that first cycle, because they say, maybe you'll have embryos that can be transferred or frozen, and so some insurances do have limitations on that. I've heard weight affects fertility. What are your thoughts of using GLP-1 agonist to help with weight loss? So I'm not sure if anybody's familiar. GLP-1 agonist are medications like they go by trade names, Wegovy and slipping my mind right now, Wegovy, and I'm sorry, that's the only one I can think of off the top of my head. Weight can impact fertility in women with PCOS. For women who don't, because there is some correlation between ovulation and weight in women with PCOS. And if you lose weight, you're likely to become more ovulatory. But that's not true for everybody with PCOS. For women without PCOS, we really encourage certain weight loss in certain body mass index or weight categories to keep it safe. If you go through IVF, for example, an anesthesiologist has to control your airway and make sure that this is safe, and that can be harder in people who are larger. The GLP-1s are not encouraged for use during pregnancy because we do not have any safety data on that. We don't know anything in large. There are people who anecdotally got pregnant and who delivered, but it really isn't in large enough numbers for us to say it's safe. So we tell people to stop them 2 months prior to trying to conceive. So some patients will go on them, have a weight loss, and then go through their IVF cycle and become pregnant. What diet, lifestyles, and supplements do you recommend to boost fertility? I love this question. I answered it before, which is all the sensible things that you should be doing in your life. Healthy diet, cut out processed foods best you can. It's hard because a lot of us work and you have to grab lunch very quickly. But avoiding processed foods, eating a balanced diet, taking your prenatal vitamin, getting adequate sleep, good water intake, moderate exercise, avoid getting overheated. In terms of supplements, I don't recommend anything in general other than just a prenatal vitamin. I feel like, a woman who wants to have a baby or a couple who wants to have a baby or anybody who wants to have a baby is so motivated. And the internet knows that. So if you start looking up supplements to help you get pregnant, suddenly all these things are pouring at you in terms of advertisements. And people just want to sell you things, and sometimes they don't work. And really, the only bona fide product we have out there in general for fertility is a prenatal vitamin. Now, there are certain circumstances where I will recommend other things. Some people are vitamin D deficient that can impact fertility, so I would check their vitamin D and start them on a supplement. But in general, just live your healthy lifestyle and don't beat yourself up too much. Does stress impact your ability to become pregnant? And this is another one that I get. And it's a great question from a medical and scientific standpoint. There is no way to test this in reality. Cortisol levels fluctuate a lot throughout the course of a day, and so we can't really reliably measure them. Stress in our world is subjective, and I hate for my patients when they come in and they say, my mother tells me I'm just too stressed. I need to not worry about this so much, and then I'm going to get pregnant. And I think that's not productive because basically you're blaming that person for their own infertility. And that's just not good or healthy or meaningful in any sort of way. We all have stress in our lives, and there are certainly people who have gotten pregnant. All of human history has been really stressful, honestly. And people do get pregnant. So I would try not to turn that in on yourself and say that you're the problem and that you're just too stressed from work or from trying to get pregnant. Let's see. Is there a diet with people with PCOS should follow? I've seen online low carb, low sugar, low dairy, etc. No intense exercise due to raising cortisol levels. A low glycemic diet is recommended, so low sugar, high protein. That being said, you need to get all your nutrients in and all your fiber and try to be balanced about it. I think moderate exercise is great. If you walk every day, if you are already a jogger, I don't think it hurts to jog. Bicycling is great. Swimming is great. I would not, unless you're trying to lose weight, start any new routines while you're trying to get pregnant. So I work on the weight loss and then try and get pregnant. Again, it's a balance of age and how much weight you want to lose. But moderate exercise is always approved. I just had my retrieval and had 8 eggs fertilized, how many embryos can I expect? Ooh, that's a tough one, and it depends on a lot of your diagnoses. In people with severe male factor, oftentimes it's not as the embryonic development is not as good. But out of 8 embryos, I would hope for 1 to 3 blastocyst. Anything above 3, I think you should think of yourself as very fortunate. People, my patients often get upset because they hear, oh, I have 8 embryos, and they get to the day of transfer, and I'll say, we have 1 for transfer, and we're watching the rest of them. And they will say, well, what happened to them? Why aren't they developing? And every embryo's got its own pace, and every couple has its own unique expectations. What are the chances of having a second ectopic pregnancy? I take it as somebody who had 1. So the chance of having an ectopic pregnancy in the general population is 2%. Once you've had an ectopic pregnancy, the probability of your second being an ectopic is 20%, but in general. Now, obviously, that 2%, it covers a lot of people. So for people who've had pelvic surgery or ruptured appendix or gonorrhea, chlamydia, or pelvic inflammatory disease, the risk of having ectopic pregnancy is going to be higher than somebody who's never had any of those things. But certainly your risk of ectopic does go up with the second pregnancy. But the good news is there's still an 80% chance that it won't be an ectopic. You're somebody who, once you have a positive pregnancy test, if you're not followed by a reproductive endocrinologist and didn't get pregnant with some sort of assistance, I would absolutely recommend that you call your OB with a positive pregnancy, and if they know that you have had an ectopic, they'll want to monitor that very carefully. Should I do PGTA testing? I'm 37, and this is a very, very, very personal choice. If you were 25 years old, I tell my 25-year-old patients, any given embryo, and don't quote these numbers, these are sort of gestalt off the top of my head, the probability of you having an embryo that's abnormal is about 10%. If you're 40, it's going to be like 60% maybe. And so doing PGTA might be a better idea for somebody who's 40 than somebody who's 25. Now, you said you're 37, you're kind of right in that inflection point. The probability of any given embryo being abnormal, I'd say, is 35%. Most chromosomal abnormalities are not compatible with even implantation. And the ones that we think about are Downs, trisomy 13 and 18, because those are compatible with implantation and progression of the pregnancy. So I really encourage couples to talk to each other about that. And if that's something you can't tolerate, then maybe you want to do PGTA. But you're sort of in that, like I said, inflection point where it may or may not be worth it to you, depending on choices that you can make. Also love this question. When should I consider freezing my eggs? I'm now 36 years old, planning to build my family in the next 5 years. And I had quoted that paper that there's a nomogram that basically tells you your probability of success. You're in your sweet spot for freezing eggs between the ages of 30 and 38. Once you pass your 38th birthday, it's still a viable option. But as women mature, you have fewer and fewer eggs that are competing each month, which means eggs that are available for us to stimulate and retrieve. When you hit your 38th birthday, or I should say in your early 30s, of those ones that we can retrieve, some fraction of them are chromosomally abnormal. As I mentioned before, that starts to rise in the early 30s, starts to rise a little bit higher around the 35th birthday, and by the 38th birthday, the slope of that curve really starts to go up. So I would say 36, 37 is the time to get this done if you're planning on using them later. But again, this is a very personal choice, and finances weigh into it as well. My doctor wants to try Clomid. If I don't get pregnant within 6 to 12 months of treatment, what's our plan B? In these cases, I'm assuming everything, semen parameters are okay because you wouldn't otherwise be in IUI. I'm assuming your uterine anatomy is normal. Most people go to IVF after that, depending on, again, your diagnosis and your age. What is the best frozen embryo transfer protocol for adenomyosis after suppression? This person's had their fallopian tubes out, so they can't get pregnant on their own. So adenomyosis is the same thing as endometriosis, but it's in the wall of the uterine muscle. And so it enlarges the uterus, and it's also not normal for it to be there. And so it can reduce, like endometriosis, it reduces your probability of getting pregnant. So in these cases, we tell people to undergo some sort of suppression. This can be with a birth control pill, more commonly with medication called Lupron. Lupron shuts down your brain's ability to make FSH and LH while you're taking it. Those are those ones that stimulate the ovaries. And that means that your estrogen and progesterone are going to be quite low. It almost feels like an artificial menopause. And how long you're on that varies by a decision between you and your doctor. There are some side effects to it. There's some risks to it. I think a month can be adequate. 3 months can be adequate. 2 months. I've seen people do 6 months in certain severe cases. You start the cryothaw cycle immediately, though, after you're done with the Lupron. And you can even continue the Lupron and take estrogen patches and progesterone shots and sort of override those. And then once you're pregnant, you would have to continue that estrogen progesterone. You would stop the Lupron, obviously. Can you speak about sex selection after PGTA testing? Do you know the sex of the embryos when you get back the PGTA results? For a long time, this was controversial. I think it's less controversial in today's world that you do get to select, and you can certainly select. It's going to be your life, not my life. So if you have both genders available and you want to transfer a 46XX or 46XY, that's totally fine. Some people want to just have the embryologist choose the highest quality embryo. When it gets tricky is, let's imagine you have a couple who comes in for sex selection specifically because they have 2 girls and they want a boy, and then they only get 46XX embryos. What do you do if they have 3 of them? And that's a hard conversation because they may say, well, I don't want to do this again. And then you have to have that conversation about what are we going to do next. But certainly you can select if both are available. Any tips on staying strong through this process, trying to conceive for 2+ years? Wow, that is a great question. And I know I've told folks this before, but I know somebody who went through many, many IVF cycles between age 30 and 40 and didn't have a success with that. They do have a healthy child now. And she shared with me that she had missed so much of her life, meaning she'd missed birthday parties and weddings and funerals and baptisms and bar mitzvahs and all sorts of life events. And she said, all I have to show for it is 1 miscarriage. And it made me so sad that she had, given up her life. And I think it's important. It's an important struggle. It is something that you need to prioritize if this is something you're doing, but also be nice to yourself. It's easy to beat yourself up. It's easy to say this, turn on yourself and say, this is my fault. I shouldn't have waited so long. I shouldn't be so stressed. I should have done something else. I should have done this sooner. Just really be nice to yourself. All the things I've said before, healthy diet, adequate sleep. Some people do acupuncture. I'm a bit of a believer in acupuncture. There's no proven data that it actually helps, but I do think it takes you to a different space in your mind. For 30 minutes, 45 minutes, an hour, it's really hard to relax. I know if I try to take a nap, let's say on a Saturday afternoon, my phone rings, I hear some car buzzing by, my doorbell rings, somebody's running for office. It's impossible. And acupuncture takes you out of that. Everything goes into a locker. You can't move because you have needles sticking out of you. If you can find something like that for yourself that just gets you in your own mind and own body and shuts everybody else out, I think that's important. Once a week, once every 2 weeks. And be nice to yourself. And if, meeting with a social worker helps, or a mental health specialist, that's also great. What's the chance of getting a successful transfer of a day 6 5 BA? Really, really good. Really good. Your age doesn't even matter. That's a really nice embryo. Let's see. There are an awful lot of questions here, so I'm sorry I didn't get to everything. There's somebody who's saying that I didn't get all my questions answered. I'm really sorry. Let me just scroll through them. Here's one it's anonymous, so I can't really figure out who the anonymous person who didn't have their questions answered, but how do you naturally boost male fertility? Again, healthy lifestyle, avoiding heat. This is particularly important for men. So hot tub sauna, marijuana, can lower semen parameters. So if this is somebody who takes in marijuana, they should stop. A multivitamin, healthy diet. It's all the same answer for everybody to some degree. It will be different for other people. Right. After an egg retrieval, an egg has been fertilized. Will the lab let you know if it stops growing prior to day 5, or do they wait until day 5 to give you an update? So I've been at 3 different centers now, one for many years, one briefly, and now Boston IVF, and they all function exactly the same. You get notification of how many embryos there are after the fertilization. If there is a planned day 3 transfer, you know how many there will be for transfer on day 3, but you may not know about the status of the others because they're still watching them. When you get to day 5, we do watch them up to day 5, 6, and 7, so there may not be an update until day 7. There's some ways that embryos are monitored where we don't see them until day 5. So the embryology team can't reach out to everybody about the status of every embryo. But at the end of your cycle, by day 7, whatever allotted amount of time for sending messages, you will get some sort of update about what happened to your embryos, how many there are. And the assumption is that if you were freezing your embryos and there are 3 frozen and you had 8 embryos, that the rest of them dropped out in development. And that is very, very normal. Most embryos don't make it to day 5, 6, or 7. All right. Well, yes, my dogs didn't get into World War III tonight, so that's all I was concerned about. So thank you, and thank you for your well wishes. And I really thank everybody for showing up, asking really great questions and really intelligent questions, and being put forward about your endeavors. And I do wish everybody the best in their endeavors and whatever you're doing.